Hello, everyone, and welcome to Session 1B, Developing a Trauma-Informed Organization. This is Allison, and I'll be your technical support for this session. A few quick housekeeping items before we begin. First, I want to let you know this session is being recorded. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services or the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Over to Will and Andrea.
Welcome, everybody, and good afternoon. We are very excited to have this presentation for you to help you all understand how to develop an organization that is trauma-informed so that your services are based on an understanding of the vulnerabilities of trauma survivors so to avoid re-traumatization. I want to thank our presenters, Mary Blake, who is here at SAMHSA, National Council for Behavioral Health, and Julian Ho of the Family Center.
And good afternoon, good morning to some of you, everyone. This is William Longinetti, Public Health Advisor at SAMHSA. And I just want to echo what Andrea said and thank everyone on behalf of SAMHSA for joining us in the first session of this track. And we hope you'll stay with us throughout the 4 sessions in the track over today and tomorrow. We put a lot of work into bringing all of these great presenters together. And we thought of the track not just as a way to convey information about program administrative issues that you might have heard before, but ways to really build capacities into your agency, such as what we're about to hear. So without further ado, I'm now going to turn it over to Liz Burden.
Thank you so much, Will, and good afternoon, everyone. I also want to welcome you all. I have the honor of serving as the moderator for today, and we'll keep an eye on the questions that you all put into the all questions box for presenters as we go. We also encourage you to use the public chat to talk with one another about the concepts and the themes that are going on, and we're going to practice that in just a minute. So our session objectives for today are to define some key principles of trauma-informed organizations, to discuss stages in creating a trauma-informed organization, to describe organizational climate, policies, and procedures that support trauma-informed programs, and to recall examples from an organization that has undertaken a process to become trauma-informed. Julian Ho is going to share with us their process of the Family Center has gone through in looking at that, and Mary Blake and Linda Henderson-Smith are really going to walk us through some of the principles and stages in creating trauma-informed organizations. So given those objectives, we'd love to hear from you, have you type in the chat box what needs to happen today in this session that will have you feel that it's been time well spent. What will make this session a win for you? Or more directly, what information about trauma-informed organizations would you like to know? So if you would put those in the public chat, that would be great, and we'll take note of that. And again, if you have specific questions as the presenters present, for the presenters, we are going to ask you to put those in the all questions box, which is in the lower left. And with that, I'm going to introduce Mary Blake, who's going to speak with us about trauma-informed organizational change, where we are today, national overview. Mary is a subject matter lead for the adult trauma and trauma-informed approaches at SAMHSA. Her other bio points are on the screen, and if you downloaded the biographies in the plenary session, you have the full bios for all of our speakers today. And with that, I want to say welcome, Mary.
Hello, everybody. I am delighted to be with you all today. I know that I've spoken with some of you, perhaps many of you, in prior virtual grantee meetings and even in live grantee meetings going back. It's a pleasure to be here with you all. And today I'm going to give you more of a big picture view of the state of the field around trauma-informed change and SAMHSA's work to that end. And then I believe that our good friends at the National Council are going to drill it down to a more hands-on level, and then you'll hear from an agency that is actually doing it. So I think it'll be hopefully very informative. As many of you may know, but some of you may not know, that SAMHSA's work around trauma-informed care and a trauma-informed approach was really framed out in 2014 when we released our paper, SAMHSA's Concept of Trauma and Guidance for a Trauma-Informed Approach. The paper was developed over a period of time, and we actually brought in the experts of the field to help us look at what the literature showed at the time and look at what people who had really been champions and innovators in this field, what they were doing. So we brought experts together in a face-to-face meeting and then worked with them virtually afterwards so that we were not recreating anything, but that we were building on what the evidence showed us at that time in terms of what does it mean to be trauma-informed, what are we talking about when we're talking about trauma, what are the core values and principles of a trauma-informed approach, and then how do you move those principles into action to build organizational change. The purpose of our concept paper was to gain an shared understanding of what we mean by trauma and a trauma-informed approach, to get agreement to enable discussion about trauma and trauma-informed approaches across different service sectors, to provide the basis for measuring how do you know when you're trauma-informed, and to provide a basis for training in TA. We put our paper out for public comment, and we integrated much of that public comment, including comments from our federal partners, to develop the final paper. I'm going to talk to you very quickly about some key highlights from the paper right now. First and foremost, I want to talk about how SAMHSA has defined what it means to be trauma-informed. Again, this is not something that we developed from scratch, but really building on and then getting endorsement and consensus from leaders in the field that a trauma-informed approach realizes widespread impact of trauma, so that awareness, that understanding that of the prevalence of trauma, and also understanding that there are many different ways that people recover, not just seeing things from the lens of you're a victim of trauma, but you're also really looking at trauma in the context of opportunities for post-traumatic growth. Second, an agency or organization recognizes the signs and symptoms of trauma, not only with the people they serve, but also within their own staff and others involved in the system. Third, that the organization is able to respond by integrating these into policies, procedures, practices, engagement styles, environment, and all the domains of organizational change, with the goal, number 4, of resisting re-traumatization. The principles that SAMHSA worked with all of these experts in the field and got endorsement from are safety, trustworthiness and transparency, empowerment, voice and choice, collaboration and mutuality, peer support, cultural, historical, and gender issues. And the experts that we worked with included people who worked on trauma across the lifespan, as well as intergenerationally. I'm not going to belabor these principles too much right now. You can download SAMHSA's paper and really read about the principles and how we understand them as key underpinnings for anything that happens to become trauma-informed. SAMHSA also kind of looked at the literature, beginning with the seminal work of Roger Fallett and Maxine Harris, who were the first people to really identify this thing as trauma-informed care and to articulate it as an organizational change strategy. We built off of that work, and then working with other partners, identified 10 domains that any organization should be looking at integrating these core values and principles of a trauma-informed approach. So these are kind of consistent with the organizational change literature, that you're looking at your governance, your leadership, your policy, and all of these other domains when you're thinking about how you're going to move your trauma-informed change strategy forward. However, it is not true that you have to do all of these all at once, so that an organization will look at those opportunities for change where they lie. Many organizations begin around training and workforce development. So it's not like you tick off all of these boxes, but this is a frame for organizations to work within as they're moving it forward. I want to talk about this issue of organizational change and really building off of Kotter's stages of change is really looking at how change happens within an organization, because ultimately it is true that a trauma-informed approach is really a fundamental change in the way an organization does business. It's not just a matter of training the workforce. It's not just a matter of changing a few policies, but it's really changing the culture of an organization. So there really has to be a sense that this is important. There have to be your trauma champions, kind of your people who are going to help move it forward. There's got to be a vision for what this change will do, how it will benefit people within the organization and those who are receiving services. You have to really think about how you communicate the vision and empower others to be part of this change. That includes service. Okay, sorry, mute went on for some reason. I'm hoping everybody can hear me. So you want to think about how you can empower others. That includes service recipients. That includes staff members at all levels. That includes community stakeholders. All of these people at different points in time will be really important to be empowered in this process. You need to identify what are the things that you think you can accomplish quickly, and really look at how you move this change forward so that people can see results, even though they're in it for the long haul. And you really want to think about how you're going to be assessing this change and how you might build in flexibilities to change approaches if that's needed, or to put in new innovations. The other thing I wanted to say is that implementation doesn't start here and end there. We know that there are some key factors around the implementation cycle, that you're really looking at building capacity and infrastructure. You're preparing your workforce with key understanding, knowledge, and even skills. You're looking at how to translate and apply these ideas to the context of practice, to the context of leadership, to the context of financing. You also want to encourage staff to test ideas out, and you really want to build in your plan for sustainability. All right, so I want to just quickly mention that this is a field in its infancy. There is no actual evidence base for trauma-informed change. We see it as a promising practice for organizational change, and SAMHSA now is really moving forward to think about how do you develop metrics, or how do you develop a measurement strategy for this change process. And And so I wanted to mention that we held an experts meeting in April of this year where we brought in leaders in the field of trauma-informed care, but also organizations that are diving deep to think about how do we know we're becoming trauma-informed, and then number two, how do we know that it's making a difference for the people we serve? And so the meeting was really designed to look at highlighting promising practice in the field of those who are actually trying to do this work. Number two, identifying the applicability of what's happening in the field to SAMHSA's key principles and domains. We want to make sure that we have domains that still work, that the principles are operational, and all of that. So we're using this work to even assess our own work, and then to identify common strategies and metrics. I'm wondering, I know I might be getting towards the end of my time, so I'm going to be moving quickly here. But that was the basis of the meeting, and these were some of the key questions that we wanted to ask all of the participants. How do you know when you've achieved your objective? Do you have a measurement strategy, and does that really align with your vision and your mission? Does it align with what you're doing? And again, how do you know it's making a difference for the people that are coming to you for services? One of our participants, Dr. Eddie Mackinger, that many of you may know at the University of San Francisco Women's HIV Program, where they really are digging deep on this. These are slides from a presentation that they gave at our measurement meeting, and I wanted you to see how they were framing their own implementation research. And so they really were looking at the environment, how they're looking at issues around screening response, and then how they're using quantitative, qualitative, and observational data or document review strategies to see whether they're hitting the mark of their effort. Sorry, I'm just trying to forward slide a sec. Here we go. And so they were looking in a variety of different contexts at whether that change was happening. Actually, I'm going to go back. So they were looking at organizational change. They were looking at the broader environment and the systems. They were looking at how staff supervision and staff development is being addressed. They were also looking at individual consumers and providers. So some of the things that they were looking at were both quantitative and qualitative data. They were looking at their records reviews, and they were also looking at pre and post data for specific interventions. So the measure of the outcomes is they're looking at each evidence-based practice they're implementing. They're looking at the clinic as a whole, and then they're looking at the patients and the clinical team. They're also looking at what other measures would be important. So they're looking at those essential trauma measures. They're looking at other consequences of trauma, and then they're looking at other outcomes of resilience or outcomes of interest. Those that are really looking at that post-traumatic growth, developing empowerment scales, looking at resilience. So they're still very much in their process. And I think what I wanted to put on the map for you all is just making sure that you're thinking about when we're doing this staff training, when we're articulating our vision for becoming trauma-informed, start to think early, how do we know if we're doing it? How will we know it's making the difference that we thought it would make? My final slide here is just looking at where are we now. So we know that this work is still in its early stages in the implementation science. We know that there's a lot of consensus around core values and principles and even domains of change. We know that there's been a lot of focus around screening and around response. But we also know that when we think about screening, we also need to think about how we open the door for people to talk about their experiences. So it's not just about screening instruments, but it's about engaging people in a lifespan and human way so that they can talk about their experiences. That helps us better understand the context in which they're coming for services. The other thing I wanted to talk about is we talk a lot about evidence-based practice, we talk about intervention, but really we also are looking at engagement and how we do these things. And so there a lot of the assessment tools are really focused on that engagement piece, and it's something that I think we need to take a look at much more deeply. Because you can have a good evidence-based practice, but it's implemented in a non-trauma-informed way. Just to say we provide trauma treatment doesn't mean we provide trauma-informed treatment. Around organizational change and assessment. So there's a lot out there, a lot of people who are calling things evidence-based. The jury's out actually on the organizational change on these claims of evidence-based. We do know that assessment tools can be helpful, but that hands-on technical assistance is really what's going to make the difference for people, because they can start their process, they can identify their domains of change, they can even use assessment tools, but it's helpful to have somebody to speak with when you run into unexpected problems or issues. And so developing a learning community of people who can brainstorm with each other is a great way to do that. There are a lot of tools and opportunities that you pay for. Some of them you pay a lot for. And so building your own internal capacity and working with your peers to do that, that change strategy is really important. Don't forget about your evaluation. How do we know we're there? And is it making the difference? And that all of these things go in a cycle. Thank you very much. Sorry to be so high level, but now it's going to come back to reality.
Thank you, Mary. And high level is good. We're up next. We have Linda Henderson-Smith, who's going to talk more about some of those processes that Mary was just talking about becoming a trauma-informed organization. Linda is the Director of Children and Trauma-Informed Services at the National Council for Behavioral Health. Welcome, Linda.
Thank you, Liz, and good afternoon to everyone. I wanted to start by just giving you guys some food for thought. This quote says, "Our core values impact who we are, how we operate, whom we hire, and how we interact with people we care for and work with." When we are becoming trauma-informed organizations and really focusing on wellness, what we have to do is really ensure that all of our actions, all of our decision-making, all of those things are made through the trauma-informed care principles that Mary talked about earlier. So making sure that when we actually do things and put things in place, we're thinking about safety, both physical safety, emotional safety, and psychological safety. We're thinking about if it actually will impact positively or negatively trustworthiness and transparency, collaboration and mutuality, empowerment, voice, and choice, and of course, if we're addressing those cultural, gender, and historical issues. So I wanted to just kind of start with one developmental framework of trauma-informed care that comes out of Missouri that was established in 2014, and it kind of gives some real tangible evidence of where you are on the journey. One thing that's really important to understand about becoming a trauma-informed organization is that it is very, very difficult to actually get there. but it is something that is possible. And so it's not a sprint. It is definitely a marathon that it will take you some time to get there. It was something that you will continuously be aiming towards. But there are stages to it as designed here, where you become trauma aware, then you become trauma sensitive, then you respond to trauma, and that's when you can then become trauma informed. I can send the document to Liz so that you guys can have access to that document as well, so you can read further about that. But I want to kind of just talk about what a trauma-informed organization includes. It includes things like a safe, calm, and secure environment with supportive care for both your clients and your staff. One thing that's really important for people to understand about becoming a trauma-informed organization is it's not, just like Mary said, it's not just about doing evidence-based trauma treatments. It's not just about saying, I do this. It's about what you do and how you do it, both internally and externally. It's about making sure that you have a system-wide understanding of trauma prevalence, impact, and trauma-informed care. It's about ensuring that you have cultural competence and humility in all that you do. It's about ensuring consumer voice, choice, and advocacy at all levels. So in not just person-centered planning where they have say-so into what treatments they get when they receive services, but also do they have say-so into what programs are being provided, the evaluation that's happening, the continuous quality improvement, program design, program evaluation, program implementation. There should be consumer voice and choice on every level of your organization and all of your services. You should have recovery-oriented, consumer-driven, and trauma-specific services, but above all else, becoming a trauma-informed organization is about having healing, hopeful, honest, and trusting relationships with each other, with clients, and with community partners. So what are some of the benefits of adopting a trauma-informed approach? These are just a few, right? We heard very clearly from Mary, there's no quote-unquote evidence, right? However, anecdotally what I can say is that it increases safety for all. Again, internally and externally. It improves the social environment of your organization and your organizational culture. It provides care for the caregivers, because one of the things about a trauma-informed organization is ensuring that there are things in place to combat some compassion fatigue and to combat the burnout that frequently happens in our field. It improves the quality of services because, again, it's not about what you do only, but how you do it. It reduces negative encounters and events, creates a community of hope, healing, and recovery. It increases success and satisfaction at work, promotes organizational wellness, and when you have all of those things, eventually it improves the bottom line because you don't have to worry about retraining new staff, right? It reduces your turnover rate. It can improve the way in which people actually come to seek service. And so understanding that by adopting a trauma-informed approach, you can benefit your organization both financially. Think about becoming trauma-informed. Now, the National Council has developed our framework for implementation as it relates to trauma-informed care, and it definitely aligns very well with some of SAMHSA's strategies. So on here, we kind of showed you where they intersect. So for our domains, we have making sure, early screening and assessment of trauma, consumer-driven care and services, making sure that your workforce is trauma-informed, educated, and responsive, making sure that you're actually utilizing trauma-informed, evidence-based, and emerging best practices. Number 5, I will say, is I think one of the most important is making sure that your environment is safe and secure for your clients and for your staff. Number 6 is community outreach and partnership building. And then number 7 is ongoing performance improvement, because as you heard Mary say, making sure that you're tracking data, looking at how you're doing things, and it's impacting your organization in a positive way is something that's very, very important. But in our model, what we do is we provide training and consultation, both face-to-face and virtually, to really help dig deep into the implementation of becoming trauma-informed. We work with organizations to make sure that they are properly assessing themselves, because making sure that you know where you are at baseline so you can see your progress is important. We make sure that we provide expert coaching and also virtual training almost monthly to make sure that we're giving you all of the information that's needed in order for you to feel that you're not frustrated and that you can make those changes. We want to make sure that you have the skills, the vision, all of the things needed to manage that complex change. Other things that come with our model are a listserv and a website that has a plethora of tools that you can access that are categorized by topic and categorized by our domains. But in our model, one of the things that we like to do, as Mary talked about, was really put people together for peer-to-peer learning and sharing. So we have ways to do that, both virtually and in person, that allows for people to really, truly learn from each other. We like to call it brag and steal, right? To brag on what they're doing, to steal things from other people. But as part of that, what we realize is that it helps people to manage the complex change, because they don't have to come up with it all on their own. So as part of our model, we require that organizations develop a core implementation team, and we require that that implementation team be cross-cutting. So cross-cutting in terms of divisions or programs, cross-cutting in terms of frontline staff and leadership. And one of the things that we truly push for is that consumers with lived experience of your services be part of that team, because it is definitely a small group of thoughtful, committed citizens that can change the world and change your organizations. But making sure that they have diverse perspectives in how things that are being implemented might actually impact them is going to be really important if you want people to buy in. You build trauma champions across your organization by ensuring that your core implementation team represents the entire organization to the best of your ability. And so this core implementation team, it kind of goes back to the slide that Mary was talking about in terms of Kotter's eight stages. This is the team that actually meets regularly, develops your vision, develops your action plan, develops your training plan, your communication plan, and really pushes things forward. They serve as a connection between our faculty and your organization, and really help us as we begin to think about where you are and where you want to be. And so one of the things that is also a part of our model is we have what's called our organizational self-assessment. We have put standards to all of our domains that say, if you meet these standards, you are trauma-informed. This is what you need. And so we have an organizational self-assessment that includes items like our screening and assessment process explores all domains of wellness, including past and present trauma and resilience. There's another one where, staff supervision includes practices aligned with trauma-informed care. Or our organization has a way to prevent, identify, and appropriately respond to workforce concerns like burnout, secondary traumatic stress, and compassion fatigue. And one that I like is our organization has policy or protocol for determining when interpersonal interactions at work are unsafe between staff and between staff and client, and they respond appropriately. So our organizational self-assessment defines trauma-informed care. It helps to develop a shared understanding amongst the core implementation team. It serves as a reference guide as you're creating your vision and your action plan. And then it helps to engage and inform leadership around what's going on and what's happening. So I have a question for you all. Off the top of your head, becoming a trauma-informed organization ultimately requires that we continually ask ourselves, what do we need to start doing, stop doing, and do more of? So I'd like you to take a moment to think about one thing as an organization that you think you may need to start doing, stop doing, or do more of, and share it with us in the chat box. So we have several people that are typing. One thing, right, is the basic training and trauma-informed mindful exercises for the team, more trauma training for clinicians. Right, and as you continue to think about things that you want to start doing, stop doing, and do more of, one of the things that is very important to do is, or would be very important to do, is make sure you ask your staff what they think that you should start doing, stop doing, and do more of. I promise you I have done that exercise with several organization staff, and they have learned so much just from hearing ideas from their staff about what would make life better for them and make the work easier for them. So I just encourage that you continue to ask yourself these three questions. Ask your staff, ask your clients, and really begin to do some deeper digging into what it is that it means to become a trauma-informed organization. So there's a couple of challenges to implementation and sustainability that have come up, in our work that I just want to highlight and talk about. The first is expectation that change would occur quickly. It's really important to understand that this definitely is a journey and a marathon. This is not something that will be done in 6 months to a year. This is an ongoing, continuous quality improvement lens to really look at all that you do and every decision that you make. So it's important to understand that and set the expectation of that early in the process. Another challenge is turnover of staff or leadership and the need for continued buy-in. It is true, there's going to need to be some continuous education and buy-in for your staff and for leadership, especially as new people come on, new people come into your core implementation team, but it's not something that can't be done. There are ways to infuse this work into your everyday, what you already have in place, right? Your everyday processes. So just understand that it's something that we know to be a challenge, but it's a challenge that can be overcome through constant communication. Yes, there is a need to coordinate resources, of course, because as we know in our field, there's never enough money to do everything that we want to do. So trying to find no-cost, low-cost opportunities or figuring out ways to partner with other people to really coordinate those resources is going to be important. There's always going to be energy ebbs and flows. I'll talk about that in a second. Mary highlighted the fact that there needs to be data collection. And of course, one thing that is really, really important to understand is workload. So figuring out a way to infuse this into what you're already doing is going to help it not feel as much of a burden. Lastly, I just wanted to say, when you are beginning this process, understand that there will be implementation dips, but understand that that is a normal process. That is a normal part of implementation. There will be ebbs and flows where you stop doing something, and all it takes really is to jump back on board, pull your team together again, and move forward. So I will now turn it back over to Liz, and we'll be here for questions if you have any.
Thanks so much, Linda. Our last presenter on becoming trauma-informed, one organization's experience, is Julian Ho. He's the project supervisor of Brooklyn Women Enjoying Life at the Family Center. You can see a little bit more about him on the bullets. And the Family Center has undergone a process of becoming more trauma-informed, and so he's going to tell you more about their experience. So welcome, Julian.
Thanks for the introduction, Liz. So I actually wanted to start off with a question for you all. Why are you interested in becoming more trauma-informed? Just in the chat box, I heard a little bit of the responses from previously that you entered in, but why might an organization, specifically your organization, why are you interested in becoming more trauma-informed? So I'll just give you guys a moment to type that in there, and then I will share a little bit of why the Family Center chose to go this route. Right, so some answers coming in, 75% of clients having trauma history, improving quality of care. Yeah, so lots of history of trauma. Exactly, okay. So in terms of the Family Center, the Family Center came out of actually the HIV crisis. So we started in 1994 as provide legal services and social services to families impacted by HIV. Basically, in terms of medication, the medication wasn't great back then. We had parents passing away. So basically, we've always had this legal arm. And as the Family Center developed, we had other arms to the agency, basically, with different focus. Like we had a children's mental health clinic, and we basically wanted something to unite the different parts of the agency, some kind of organizing principle. So that's one of the main reasons why we wanted to look into trauma-informed care for agency. We really wanted to improve the agency culture, reduce critical incidents, increase staff engagement, and improve retention. So in terms of critical incidents, if you could think about patterns in an organization in terms of like incident reporting and things like that, we wanted to make sure that all staff, regardless if you're providing direct service or if you're answering the phone or if you're at the front desk, if you're in reception, basically, that all staff across the agency were trained in trauma-informed care, especially frontline staff. First impressions mean a lot. So in terms of agencies, clients interacting with an agency, that first impression that the client has from your agency really matters. So you want to make sure that all staff, especially staff that have first contact with clients, are trained in trauma-informed care. In terms of staff engagement, keep in mind your staff, your employees it's basically the agency's most important resource. So you want to make sure that your staff are engaged, well trained, know their responsibilities, and could basically do their job well. It was mentioned before that hiring staff is incredibly time consuming and expensive. So as much as you can retain staff, in terms of retain staff and retain the individuals you work with, it's really important. In terms of how the Family Center, the question that Mary threw out, how are we measuring impact? The Family Center, we wanted to look at basically a pre and post questionnaire. So we use the framework, this organizational self-assessment, with the assistance from the National Council. So keep in mind these examples that are listed here are not actually from the National Council's self-assessment, but these are general questions that can be found in other assessment tools. And each bullet point looks at a different domain, basically. So thinking about your organization, does your organization have a physical environment that's safe and comfortable? Do staff have regular team meetings? Supervision is really important. So in terms of making sure that that there are regular scheduled meetings taking place, both administrative supervision and clinical supervision, both are equally important. Staff are trained in de-escalation strategies. So going back to what I said about patterns of incidents with staff, if you're noticing that certain incidents spring up with certain staff in your agency, thinking about how you can train not just that staff, but staff across the board in de-escalation strategies. So we had someone from the National Council come in. Karen Johnson was a consultant that we were working with, and she did basically a training across the board that involved role playing and things like that. And actually, we had scenarios. We had staff come up with scenarios, challenging scenarios that they encountered day to day, and we basically role played them out. What happens? How do you respond to a client that shows up to group under the influence of alcohol? How do you respond to a client that becomes upset or angry on the phone with you? And we just took the time to just role play that out and practice. And that was really helpful, and we got really positive feedback from staff. On the other side, so not just a self-assessment from staff, but we sent out surveys to our clients. Very important that you get feedback directly from your clients of what's their perception of, because they're the one receiving the services. So we had questions, like indicators we were looking at, like staff and the intake process are sensitive to my personal struggles and life history, and basically a Likert scale of strongly agree, disagree, things like that. There were a couple of questions in the public chat. I was keeping my eye on the public chat where people are describing, were asking about how do you, during the intake process, how do you ask questions in a trauma-informed way? And that's really important. I would say that even just allowing, as you're doing the GIPRA, because we know from the GIPRA all those bubbles, and they're very personal questions, especially about sexual history, drug use, and things like that. So we found that even just letting the clients know, hey, just a heads up, we're asking you lots of personal questions. You have the right to refuse, and if you don't know, that's fine too. Because what happens sometimes is there's always this power dynamic between staff member and an individual receiving your services. So you always want to keep that in mind. There are bubbles on the GIPRA for don't know and refused. So we always want to basically keep in mind voice and choice, giving the participants in your program an opportunity to say no, like I refuse to ask this question or answer this question rather, and that's fine. That's what those bubbles are for. Ideally, you want to have the most accurate answers as you're collecting the questions, but the client has every right to refuse a question and things like that. And you want to basically preface. Make that statement and preface your questions with that statement and allowing the clients an opportunity to not answer the questions. In terms of feeling safe within the walls of the agency, depending on where your agency is located, that's like you're going to have different levels of control with that. The Family Center, we're in the heart of Bed-Stuy. There's lots of traffic, and it's a really busy intersection. We don't have control over what's out there, basically what the client has to pass in order to get into our building. However, we do have control over in terms of how we're setting up the waiting area. Are we making sure that there's that it's welcoming, that it's well lit, that it's that basically we have like some quiet space basically if there's kids involved, and we have some space to basically like let if we need to like separate clients and things like that. And that comes in really handy in terms of when incidents pop up and things like that. So someone wrote in, like, are there resources for de-escalation? There are resources out there. I'm gonna pass email Liz some resources for de-escalation, like general like de-escalation tips that I've shared with my staff that come in very handy. So I will make sure that gets passed to everyone in this workshop. So what steps do you have to take as an organization? Someone mentioned in the public chat before, what do you need to do more of is provide general trauma training for all staff. I know in New York City, there's like a initiative, NYC Thrive, that offers a free 8-hour mental health first aid training. So that's actually what we opted to use to train all staff at the Family Center. And that's like a very good general overview of how to respond to somebody who's going through emotional or mental health crisis, and how do you connect an individual to care. So that's one of the trainings that we used to train all staff. And something to also keep in mind is I realize it's going to be difficult to basically take a day off, especially with larger organizations. You don't necessarily have to shut your agency down to train everybody, but what we found was it was really beneficial for staff from different departments to be able to interact with one another and everyone to be on the same page when it comes to trauma-informed care. So we actually did that. We did basically close our agency down, let our clients know ahead of time that we are, for one day, our staff are being trained in this in trauma-informed care, and it's something that we value, that's important to us. In terms of our core implementation team, we decided to meet twice a month. The reason for that is if we met once a month, if the scheduling didn't work out, we would basically miss that entire month, and basically we didn't want 2 months to go by without meeting. So strategically, we opted to meet twice a month. And just like Linda mentioned before about the importance of having this cross-cutting participation from all staff, we made sure that basically every department was represented in this core implementation team. We also had consumer involvement, someone that we served with lived experience. If you think about your agency, there's always going to be clients that are basically that you've served for a long time, that whatever transformation your organization goes through, they will basically, they're your cheerleaders. So you want to think about getting those individuals involved into your your core implementation team. We formed different subcommittees, breaking down based on the different domains, basically. I also want to, just to wrap things up, the key takeaways in terms of what we've learned is trauma-informed care became the organizing principle for our agency. We've had basically all staff trained in general trauma-informed care. And I do want to mention challenges and barriers. Communicating through buy-in is tough, but I want you to think about who are the trauma champions in your organization. There's always going to be staff that are more interested, less interested in terms of coming on board. But identifying the trauma champions in your organization to basically tip the balance and create a cultural shift in your organization. I realize I'm out of time, so I appreciate your time. Thank you so much, everyone.
And thank you, Julian. We're at the end of our time, and so we don't really have time for live question and answers, but we do have time, maybe a minute, if you have questions that you want to type in the all questions box, and we will get them to the presenters. For all the conference, we're going to be collecting any questions that didn't get answered and making them available to all the conference participants after the conference. Here's contact information for presenters, however. Also feel free to reach out to them directly via email. I'm sure they're more than happy to answer the questions, answer your questions about